All right, welcome everyone to the PFCC Partners Community of Practice Workshop this September. Yes, excited to see that we are moving into fall for those who, really enjoy the fall weather. I'm a summer girl myself, but I'm kind of over the heat here in Northern California. So I'm ready for fall as well. We have a great presentation today. Excited to be joined by Alex Topper from Comagine Health. So we'll get to that introduction in just a minute. But first, we are recording, and you will be able to find this recording as well as all of our community of practice workshops on our YouTube channel, which we'll make sure that all of you get. Live transcript is available if you click the CC button on your Zoom toolbar as well. So that is available to everyone. All right. And so, hi, I'm Lindsay Galley. I'm the Vice President of Programs at PFCC Partners. I'm filling in for Naomi this Friday. Really thinking about everyone and anyone who is in the path of Helena in Florida and Georgia and on the southern East Coast, including our counterpart Naomi. So I just wanted to do a quick introduction to PFCC Partners, and then I'll pass it off to Alex. So PFCC Partners is a patient-powered organization, and we have a mission to center the inclusive human experience of health by reinventing through radical collaboration to truly be a catalyst for system transformation. We have a vision that, I know is shared with many others, which is a health system transformed and one that works with people and through communities as a partner in their well-being. We bring all of these values to the work that we do, and happy to bring them or share them with you today. A little bit more about PFCC Partners. So we know that healthcare, especially in the United States, is a very complex system. Its systems are difficult to navigate and even more difficult to change. So our organization, PFCC Partners, we work within that system to help open space for patients and family caregivers to drive improvement. And who fill those spaces? Well, the PFA network, these are patients and family caregivers who are all serving in the role of patient-family partner. They fill those spaces with their impactful stories and insights. So that's a little bit about how we work, and you can find more information about us at pfccpartners.com or pfanetwork.org. I'll share those in the chat shortly. We went through that rather quickly because I want to get right to our presentation today. Really excited to be joined by our partner at Comagine Health, Alex Topper. Alex is an improvement advisor in population health at Comagine Health. And I had the pleasure of working really closely with Alex over the last, I think, year and a half, 2 years or so to support the multitude of listening sessions that were held, listening to people, to patients, to family caregivers, beneficiaries, to hear about their experiences within the Medicare system. So I'm really excited to be joined by Alex today to talk through that program and what they learned. I'll stop sharing, Alex, and you can take it away.
Great, thank you. Let me first share my screen. Are you seeing my slides, the green slide deck? Perfect. Awesome, well, I'll get us started then. My name is Alex, as Lindsay said, thank you for the introduction. I'm an improvement advisor at Comagine Health. I myself am located in Vancouver, Washington, which is right outside of Portland, Oregon. I was previously located in Seattle while I was working for Comagine. So we have work kind of going on in different cities and different states across the country. That's just where I am located, but I have team members everywhere. Today I'm going to share about a project that we worked on, as Lindsay said, in partnership with PFCC Partners between 2023 and 2024. Please feel free to put questions in the chat, raise your hand, unmute. I do not have a problem with being interrupted, so please feel comfortable interrupting. I'm totally happy to take questions as we go if you don't want to hold them till the end. And I also will say I'm a very fast talker, so if I'm talking too quickly, I'm from New York. We all talk fast. So if I'm talking too quickly, please tell me and I will definitely slow it down. I can get kind of quick and chatty. So I'm going to share about our work collecting experiences in the Medicare system, perspectives from patients and family caregivers. And you'll notice throughout the presentation, I might say patients or I might say Medicare beneficiaries. For this project, that's the same thing. We work with Medicare beneficiaries. I'll share a little bit more about that in a moment. And if you hear me say family member or caregiver, that's also two terms I'm going to use interchangeably. For some situations, some people that participated, they're a family member of a beneficiary. Other people are a friend, chosen family. There's all kinds of people who might be contributing to patients' care. So if I say family member or a caregiver, they all mean the same thing. So just keep that in mind. So Comagine Health, a brief note about who we are and what we do. Comagine Health is a national nonprofit healthcare consulting firm. We work with all different kinds of partners, patients, healthcare providers, insurance, local government, community organizations, and others to work on sustainable improvements in the healthcare system. So working on improving healthcare, as I think everyone here today is working on the same goal. And we serve as the Medicare Quinn QIO for 6 states. So what that means is we are the quality improvement organization for Medicare for the states of Idaho, New Mexico, Nevada, Oregon, Utah, and Washington. So we have work in quality improvement in all of those states. And I saw somebody in the chat say they're joining from another QIO, which is great. All of the states in the United States have a QIO that works in that area. So Comagine is the QIO for these 6 states that I just listed. And I'm joined by our teammate of mine, Savannah Smith is here. I'm going to let her take over and sort of share the information on this slide, and then I'll pick back up when she's done. So Savannah, take it away.
Thanks, Alex. And I'm not going to take credit for this slide because this was actually created by Lindsay, and I hope everyone can hear me. I'm at the car dealership getting my car fixed, so I'm so sorry for any background noise. Okay.
Yeah.
So as Alex mentioned, my name is Savannah Smith. I am the Health Equity Program Manager for Comagine Health. And within our Quinn QIO, I focus to engage patients and those with lived experience into our deliverables for CMS. And with that comes our partnership with PFCCpartners. We have been partnered, give or take, about 3 years. And so this slide really explains the roadmap and the engagement process for which we really engage and incorporate those with the lived experience in our deliverables, activities, interventions, etc. I won't read it verbatim, but I really just wanted to give a high level of, we really focus on engaging from project initiation. Sometimes that looks different for every project. As you'll hear Alex mention today, the care coordination team, which she does fabulous work on, they hosted listening sessions. So engagement can look like listening sessions, document review, brainstorming. Really just depends on the deliverable, the project, the population, and the area in which we are impacting, as well as turnaround time. So some of our projects are really quick, some take time. But I hope this slide gives you an idea on how, from start to finish, we engage, impact, and celebrate at the end of our process.
Awesome. Thank you, Savannah. And I'll call out to another teammate of ours is also here. You'll probably see her name in the chat, Alberta Davis, located in New Mexico. Just wanted to call out that we have another Comagine team member here who was also part of this work, so could possibly answer some questions. I'm trying to keep an eye on the chat, so if anything comes in there, Lindsay or Alberta or anyone, feel free to stop me, but I will try to keep an eye on it as well while I go. Alrighty, so getting into it. So objectives for our time together here today. I'm going to walk us through a brief overview of the current state of hospital use for Medicare beneficiaries. I'll outline the steps for partnering with PFCC partners to host listening sessions. Savannah just sort of gave that overview, but we'll dive a little deeper into that. We'll summarize key findings from our listening session project and go over the main themes that we heard. And then we'll explore how some of these themes might align with clinical practice if we have any clinicians in the group, or we can just kind of discuss them further about, how you see these things being addressed in healthcare. Okay, so as Savannah mentioned, the CMS measures, so all of our work on the Comagine Health Medicare team is guided by what we call our CMS quality measures. So these measures are goals that are outlined by CMS. So CMS is the Center for Medicare and Medicaid Services, so the organization that manages Medicare and Medicaid in the country. So they outline these different goals to improve the health and well-being of beneficiaries, and providers and organizations like Comagine are responsible for coming up with solutions, interventions, programs, different processes to address these measures in healthcare. So our care coordination team that I'm a part of and Alberta's a part of are working on 3 different measures. So the first is decreasing Medicare beneficiary emergency department visits, targeting superutilizers or people who use the hospital fairly often. I'll also say that the term superutilizer is sort of going a little bit out of fashion. It is how it's written in the measure, but I will not be using that term throughout my presentation. It's kind of a little bit, there's new terms being developed to better capture what that means, but it really just means people who are visiting the emergency department more than X amount of times over X time period. The next measure is decreasing hospital utilization overall for beneficiaries, and then finally decreasing the total number of hospital readmissions within 30 days for beneficiaries. So people getting discharged from the hospital and then having to return to the hospital less than 30 days after that discharge for some reason, whether it be related to the original hospital visit or different, it's still kind of counted in there as a readmission. So what does the data say about these different measures? So in our 6-state region, we use Medicare claims data. So the numbers on this slide are representing the year that's listed on the bottom of the slide. So it's May 1st, 2023 through April 30th, 2024, so calendar year. Of course, there's data since then because April is a couple of months ago at this point, but then the numbers don't change that significantly month to month. So we can kind of operate as if these numbers are pretty current. So about 57% of beneficiaries utilize the hospital in a year, in the calendar year, whether that be through an emergency department visit, an observation stay, or an inpatient discharge. About 2% of hospital discharges result in a readmission within 30 days for beneficiaries. And then superutilizers visit the emergency department about 3 times per year is the average number. And I see in the chat a question about superutilizer. You have a great question, Karen. The question is, what happens when superutilizers are identified? So superutilizer isn't necessarily an identity that every provider is looking for or every hospital is tracking. But CMS looks at it because they feel that there's probably a difference in need between someone who's maybe visiting the emergency department once a year because they fell and they hurt themselves versus superutilizers who are going fairly regularly. Does it mean they don't have access to primary care? Does it mean they have maybe significant health issues or maybe behavioral health issues that are leading them to use the hospital? Maybe they have lack of resources. So people who are experiencing homelessness or housing insecurity maybe are visiting the hospital more often. So superutilizer is a term that's sort of used by CMS to capture these people that are using the hospital fairly often, as the interventions that are going to help those people might look different than for somebody. If you fell and broke your arm, you kind of have to go to the hospital. There's not really other options. Whereas maybe superutilizers might be using the hospital when they could be using a different type of care, or they could be supported differently. I hope that's a helpful answer. And then I see, sorry.
Yep. Nope. I was just gonna thank you for that response and recognize that Joe has his hand up with a question.
Joe, please.
Thank you. I was just curious. I know that hospitals are penalized for readmissions if it goes under 30 days. But the question has to do with penalties. Does CMS also penalize Medicare beneficiaries for the goal number 1 and number 3, super utilizers? who gets penalized, like we do after readmissions within 30 days?
Yeah, that's a really great question. I'll start with the super utilizer piece. So as far as I understand it, the hospitals aren't necessarily penalized if somebody is using the hospital more frequently. But what ends up happening, as I'm sure you can imagine, is that the healthcare cost for that individual is quite high. So
Um,
that, sorry, go ahead.
Excuse me, I was agreeing, yeah, just agreeing with you.
Yeah. Yeah, I know it's hard on Zoom. We're all talking when we talk at the same time. But basically, I don't believe there's penalties for the super utilizer visits other than the fact that the hospital has higher healthcare costs, which can then lead to different rankings and different penalties in other like broader measures of the hospital's performance. And then as far as the hospital use side, again, I don't believe that they get penalized for people visiting. I think the reason the readmission measure has a penalty attached is to sort of, and it's debatable if the penalties actually lead to these positive changes, but I think the idea is that if a hospital is getting penalized for that readmission, they might spend more time at hospital discharge to make sure that the patient is getting discharged into a safe environment with the resources that they need. And that way, the hospital is accountable for not having that person return very quickly, which would indicate that maybe at the time of their discharge, they didn't get what they needed. So if that, I hope that answers. I'm not super well versed in the penalty side. We don't work for Medicare. I work for Comagine, so I don't have all the details. But that's my understanding, is that the readmission is really just, what could you have done differently at that initial visit that could have prevented this readmission, which then costs money, costs resources, and maybe poor outcomes for the patient.
Thank you.
Sure. And I see another hand from Nadine.
Yeah, and if we could just do Nadine's question and then keep moving along, I think we'll get a lot of questions throughout the presentation, Alex. So want to make sure you can cover all of your content. So Nadine.
You bet. Thanks for taking my question, Alex. And please talk fast because we can learn twice as much. Is there any way to quantify whether bias comes into play that contributes to so many recurring admissions? Not just bias, but is it ever looked at from that side of things, from the clinical side? Like, why do people keep coming back? Are they not treated properly or thoroughly enough? Or do clinicians just kind of dismiss them? And you know what I'm saying? I don't mean to be negative about it. I'm just saying there's two sides to every coin.
Absolutely. Yeah, that's a really good question. And we'll get more into this throughout the presentation about what beneficiaries' perceived experiences are. And that's a great segue into why we did this project.
Well, you're welcome.
Yeah, thank you. I would say there's my struggle with the readmission measure, and I could talk about this for so long, but I'll keep it very brief, is that in my opinion, every single person that gets readmitted has a different reason. So you could find themes like they're not getting good enough education at discharge, and then they're ending up hurting themselves and coming back to the hospital, or they're not getting enough counseling on the medication and then they don't know how to take it and then they end up back in the hospital. But there are so many unique reasons. So this measure is really challenging to work on because every reason could be different. In some areas, there isn't primary care available or there isn't an urgent care. So a solution might be, oh, well, instead of going to the ER, why don't you try going to urgent care if it's not a major health event? But what if you live somewhere that doesn't have an urgent care? You don't have an option. You have to go to the hospital. So the measures are a little bit challenging. So we try really hard at Comagine Health to honor the measures, but not let them drive every single thing we work on, because at the end of the day, there are so many reasons for these different patterns.
Thank you.
So it's hard to make a project to address everybody. And I'm going to move on as at Lindsay's advice, but any questions we don't get to, I'm very available via email, so we can always talk further about anything. So onto the listening sessions, keeping all of that in mind, the measures and the things we're working on, the care coordination team decided to facilitate listening sessions throughout the year of 2023. We hosted 6 sessions. 3 of them were for Medicare beneficiaries. 3 of them were for family members and caregivers of beneficiaries. All of the sessions took place on Zoom. They were 90 minutes long. We had between 2 and 5 participants per session. We tried to keep the groups fairly small. All of our participants did come from either an urban or a suburban setting. We didn't have any participants that explicitly shared that they were from a rural or frontier area. So that is something for us to consider for the future, that their experiences might be different. All participants shared in English for this iteration of the project, but that's definitely something we can change in the future if there's people who would like to share in a different language. And then, as Lindsay shared, all of the sessions were co-facilitated by Lindsay and got great support from her. And the discussions during these sessions really centered around satisfactory and unsatisfactory experiences in healthcare, particularly in areas of primary care and hospital discharge. So those were kind of what the questions centered around. Why did we do these listening sessions? Lindsay gave a great overview and Savannah gave a great overview. But as I'm sure you can imagine, a lot of the work within healthcare and for Medicare really centers around hospitals, clinics, providers, people actually delivering the care within the four walls of these facilities. But there's sort of this renewed attention being paid to community-based work and work that happens outside of the four walls of the hospital. So if someone is discharged from the hospital, what are the resources in their community that might be able to support them in maintaining good health, avoiding going to the hospital again? It's not only the doctor's offices. What other things are out there that might be supportive? So in response to those changes, Medicare is really encouraging organizations like Comagine to focus on community-based approaches. So we really wanted to turn our focus onto beneficiaries themselves and caregivers themselves to get information about their real and lived experiences in healthcare, hoping that that information shared could provide insight into future projects, future goals for Medicare. And so this slide here really just talks about the importance of listening to lived experiences. I'll read along with you. Listening to lived experiences is an essential part of person-centered care, which empowers beneficiaries and providers to make effective care plans together. And that definition of person-centered care on the slide comes from Medicare. So now that you have the background, why did we do this project? I'm going to tell you about how we did the project. We'll go through this part a little bit quickly in the interest of time. But first things first, we had to secure buy-in. So we had to identify, is this even something that the hub is interested in doing? Is the Patient Family Partnership Hub interested in hospitalization as a topic? Do they want to work on this with Comagine? So we learned from the SBARs, the Situation Background Assessment and Recommendation Reports, that Savannah and our people working on the PFCC Partners work shared. And we found that yes, hospitalization was a priority for this group. It was something that they really want to work on as a team. Second, we had to contact the hub. So we submitted an engagement request. You can see on the slide, there's just a screenshot of the PFA Network Engagement Opportunity Request form. The form asks questions about the project background, why you want to do the project, who would be responsible for what. And then we filled that out, we submitted it, and then Lindsay reached out to us so we could begin planning together. Next, once we had the green light to do the sessions, we had to do the recruitment, so recruiting participants. That was, again, supported very much so by Lindsay. We created and distributed an interest form that you can see here on the slide, and everybody who was interested would fill it out, indicate which sessions they were available for, and then submit it, and then we would reach back out with the calendar invite and the link to the Zoom meeting so that they could participate. So we had two, one for beneficiaries, one for caregivers. Then we had to prepare the materials for the session. So we developed a discussion guide. The Comagine team, along with Lindsay, came up with some questions and prompts to guide the discussion. Our goal was really to keep it more conversational. We as a team agreed having a really kind of rigid interview style wasn't the way we wanted to go with this project, just to sort of honor the lived experience and just kind of let the conversations happen. But we did have things that we wanted to know about. So you'll see in the picture on the slide, the bolded questions were kind of the main questions we asked. And then those unbolded, italicized text is all kind of follow-up prompts. Like if we asked a question and the group didn't really have much to say or didn't really, understand the question, we had these different prompts. So for example, who's the first person you turn to for medical advice? And then the kind of backup prompt is, do you call your family? Do you call your PCP? Do you go right to the hospital? So we really wanted to keep it informal and make sure that we spent more time listening to experience and less time like asking a lot of really specific questions. Then next was to host the listening. Whoops, there we go. Host the listening session. Kind of self-explanatory. We facilitated the sessions and took a lot of notes and made sure that we got some good insight, to be able to turn into some sort of final project or final product, I should say. And then finally was creating output. So we wrote a written summary report. There's a picture on the slide of the report itself and the link to download. I'll make sure that PFCC Partners has the slide so you can download if you'd wish. So after collecting all the information and findings, what did we want to do with that information? So we wrote this report to share out with different partners. We also shared the report directly with CMS. We've presented on this work at conferences, including the PFCC Partners Conference in 2023. We were there in LA presenting on this work. And then presenting at meetings like this one today, where we're just sharing out what we learned and in the hopes of just sort of sparking discussion. As far as hosting the sessions themselves, so successes and some challenges, I would say overall it was highly successful. Partnering with PFCC Partners was honestly a breeze. I think it's just such a great partnership that Comagine and PFCC Partners has, and just feeling really supported by Lindsay and her support and Naomi's support, Brittany's support. Successes, I would say, smooth process for partnering. It was pretty clear how we could get this project off the ground. Our participants were highly, highly engaged. We got such good information. People were sharing quite a bit with us, which was really helpful. And then as far as challenges, it was challenging to recruit advisors, especially because the first round, we kept it to our 6 states. And then once we realized that wasn't kind of going to fill the seats that we needed to fill, we opened the recruitment to the national network. One thing I'll also note, it's not on the slide, but unfortunately for this project, Comagine was not able to provide financial incentive for participants, usually a gift card or something like that. But because of our contract budget and some of the rules around our contract, we were not able to incentivize with a financial incentive. I think in our ideal world, we would be offering these incentives to just show people that their time is important and matters to us and that we value their time. So that's something we really want to consider for future projects, is budgeting in some of that. Another challenge was internet issues. Some of our participants had issues connecting. So we either troubleshot, I guess, the issue. And then in some cases, or in one case, we invited the person to come to the next session when their internet was a little more stable. And then finally, as I'm sure you can imagine, summarizing such rich information in just one document or one presentation is really challenging. I think these are experiences that people are experiencing every single day, and we want to do due diligence in summarizing and amplifying the voices. But it's hard to do that when you get such good information and also some very specific information. Some people really were speaking very specifically to their own experience, as they were encouraged to do, but that might not apply to every single person. So trying to sift through the kind of major themes was challenging, but a great exercise. As far as themes, so I'm going to go through this slide pretty quickly so we could get more into the meat of it, but very high level, these are the major themes that we learned from the beneficiary sessions. I'll just read through them really quickly. So one was supportive relationships with primary care providers, specialists, and family members. So having supportive relationships led to better outcomes. A coordinated healthcare system. So healthcare systems where hospitals, clinics, medical records, maybe community-based resources are all working together was definitely preferred. Access to quality care, so things like timely appointments, whether that be getting an appointment with a primary care provider, getting a follow-up appointment after hospitalization, and telemedicine as an option came up in conversation. And then education and training, particularly following hospital discharge, was a huge area of need that we'll get into a little bit more. So this slide, this kind of illustration up here just shows the different people that are part of a coordinated healthcare system, or I should say the different organizations. We learned that beneficiaries pretty unanimously viewed coordinated care system as essential for better experiences. So things like strong communication between hospitals and the clinics, timely follow-up after hospitalization, especially active follow-up. So beneficiaries going to the hospital, being discharged, and then they're really wanting that follow-up from their provider to, make sure everything's okay, make sure maybe the issue that they were hospitalized for has sort of been addressed, or make sure that they're knowing how to care for themselves after discharge is something that came up quite a bit. And then ease of access of medical records was another big concern. So, if you see different providers in different systems, sometimes you are responsible for sharing the records. That can be confusing. Every clinic has a different way to go about sharing your records. So there's just a lot of complication when hopefully, as we continue to develop technology in healthcare, it can help us make these things easier. But currently it feels like a bit of a challenge still. This slide, these images are directly in the report. So if you access the report, you'll be able to read these more thoroughly. But these are just paraphrased comments from beneficiaries that represent some of the main themes that came out in discussion. So the top yellow boxes there are about family members and caregivers. So one person said something like, during hospitalization, I wasn't in my best state of mind and I wasn't best equipped to take in important information. I'm sure anyone who's been hospitalized can probably resonate with that. It says, without my family member or caregiver advocate with me during my hospitalization and discharge, I believe I wouldn't have received crucial care. So that's a big concern. The other yellow box says, my advocate was very involved in decision-making and helped me to better understand my condition and treatment. So again, having somebody there with them felt helpful, but we know the reality is not everybody has someone that they would take with them, or maybe their loved ones live far away, or maybe they're really living independently and don't have that support. So hearing that the family members and caregivers were helpful is obviously a positive thing, but knowing that that's not always accessible for everybody means that the healthcare system can't just assume that everybody has that support and needs to really accommodate for that. The blue boxes you'll see are about primary care. So I'm just going to read through them. The most important part of a positive relationship with my PCP is shared decision making. I want a PCP who treats appointments as collaborative and supportive rather than instructive. We heard that quite a bit. I think there used to be sort of a attitude in healthcare, still sort of is changing, but there's sort of an attitude of, the doctor's the expert, they know everything, I'm just the patient, I don't work in healthcare, I don't know these things. But I think more and more providers are really understanding the importance of helping patients come to a decision. So our doctors really, or our providers really are serving us best when they're helping guide us in decision making and involving us in our own decision making, rather than telling us what to do, sending us home and getting mad if we don't follow the directions. So that shift, I think, is really important. It's something that I see a lot in our work. We also had someone share, it's important to me to have a provider who genuinely cares about my health and well-being. A very common experience that was shared is, somebody had been seeing their primary care provider for decades. Their family doctor has seen everyone in their family, their kids, their grandkids. And then maybe that person retires, maybe that person leaves the practice, maybe they move. And then whoever kind of comes in to fill in the practice, a lot of the patients don't feel like they have a strong connection with that person, or they're so used to this really beautiful relationship they had with their provider that it can be hard to adjust and accommodate if you don't feel like the new person really cares or is that invested in your health. And then finally, I'm very happy with my providers who are patient, caring, good listeners, and thorough. I love that quote because I think we all hope that all providers are like that. And so that's just telling that people feel so happy to have that relationship with their providers, when maybe it could be more of the standard. And then the green boxes are about specialists. We have, like many beneficiaries, I use a specialist for various aspects of my care. People shared using orthopedics, cardiology, obstetrics, and gynecology, all different specialties. And in some cases, people even reported that they use their specialist as sort of like a pseudo primary care provider. So they have a certain condition that requires them to see a specialist. And in some of those cases, they're not even seeing a PCP, they're just having their specialist sort of manage their care, which not all specialists are willing or able to do. So that could put people in kind of a hard situation. We have a strong relationship with my specialist, is focused on shared decision-making. Again, people more and more want to be involved in their care. They want to be involved in their decision-making. They want to feel like they have autonomy and that the providers are really providing the information, and then together they're making decisions. So I think that that's, if I could have one key takeaway from this whole project, that would really be my first one, is that people want to be involved in their decision-making. And then finally, again, same thing. People have positive experiences when they're involved in their care. Okay, so moving on to family caregiver sessions. So major themes from the sessions are here on this slide. I would say the most common thing that was shared, again, was about the advocacy. Caregivers and family members really had to advocate strongly for their beneficiary, whether that be asking questions, whether that be making appointments, communicating with providers, getting information and resources. In some cases, advocating for which types of care and treatment that they think the patient needs, or tests. So a lot of advocating and really having to ask for more information and really kind of stand up for their patient or loved one. Communication, again, including access to a patient portal or having good end-of-life discussions in a timely manner. All of these different pieces of communication were really important to caregivers. And then finally, education and training, particularly around discharge and medication. Something I think is worth noting is that all of our family member caregiver participants have extensive professional experience in healthcare. I think that's probably why they're involved in the PFCC Partners work in the first place. But even still, all of those people commented that they still struggle to navigate the healthcare system as an advocate. So some of them were providers, more of them were kind of advocates, leadership, board member type positions, but even still are struggling to access the system. And I mean, I can speak for myself as well. I'm talking about these things all day, every day, yet it's still hard for me to communicate with providers, get an appointment, get the medication, get the pharmacy on board. It's a lot of work. And beneficiaries, particularly beneficiaries who are experiencing difficult health issues, it's just a lot to have on their plate. And so the advocates really are doing quite a bit of work to do this coordination, which, again, there's pros and cons to that, particularly for people who just don't have someone in their life doing this advocacy. It can just be really overwhelming. So these, again, paraphrase summaries from the family member caregiver sessions. So for advocacy, this is, I would say, what we heard the most. This second quote down here: as an advocate, I know I need to speak up and be difficult. If I don't, things go wrong. This is a hard thing to hear because not everybody feels maybe comfortable or empowered to really ask questions, again, especially if you're in environments with providers who are not as forthcoming with information. You can really feel like you're bugging them or you're bothering them, but a lot of our advocates said they had to sort of put that anxiety aside and just go for it and just really advocate and doctors. And that can be a hard position to be in as well, when you feel like you're having to really fight for certain tests or certain medications. And there's of course a balance. I mean, I think we all want to trust that our providers are ordering the appropriate level of care, but it's hard to trust that. Like it can just be challenging. So things about advocating, things about when I ask questions or want information, I'm dismissed and it can be intimidating, was another experience. I don't always know when providers are prescribing procedures, medications, and things that are necessary, or when to speak up and ask about alternative options. So that came up quite a bit as well. As far as communication, I think a big piece was I need an easy way to contact providers. So we have so much technology and so much capability now, and something that I was so interested in and impressed with during the sessions is the way that seniors and beneficiaries have really adopted technology. I think there's kind of a misconception that certain generations of people are not able or willing to access technology. That was certainly not true for the people in our groups. And so while yes, we have these people that are willing to access technology, there needs to be some sort of ease in the technology. It's so frustrating to every doctor you go to, you have a different login and a different record, and the doctors can't see each other's records because they're not in the same system, or they are in the same system, but they're not communicating. So I think it's hard to be excited about technology when it feels still like there's so many kinks that need to be ironed out. But the easy communication via technology is something that I think we really can pay attention to. All the players in patients' care need to be working together as partners. I think that's everyone's ideal situation, is that all these people are coming to the table and working together. And then interestingly, the end of life discussion, this was one topic that we talked about with the caregivers. The end of life discussion sometimes only came up when there was a decision that needed to be made, when we know that the best practice is that discussions should really start earlier when the beneficiary is well oriented and able to make decisions so that they can be an active part of these decisions. So that was something that came up that we have started considering how we at Comagine can help support this sort of end of life piece of the work as a way for maybe also pushing the hospital measures. If people are, if somebody's wishes are to not receive certain levels of treatment, but that's not known or documented, maybe they're then receiving treatment or care that they don't want. And that's another healthcare cost, like services that a patient is not interested in. And then finally, education and training. Training and instruction for caregivers can directly prevent emergency department use. This is something that is key to this work, is that if we're helping caregivers and family members really understand their patient or their loved one, then maybe that can prevent a hospital visit or a hospital utilization. I'm sure we can all imagine an example. During the discharge process, I didn't understand all the information I needed to know. This was super common in both caregiver and beneficiary conversations. Some cases you're getting handed like a huge stack of papers, and it's hard to go through that. One, you're in a kind of a difficult, vulnerable place upon being discharged from the hospital. And two, some of this information is very technical. Some of it is very general. Sometimes you read a discharge sheet talking about a condition that you have, but it's not super relevant to you and your specific experience. So some of that information might get lost. Information about medication, as the next quote talks about. I'm often not educated on medications, and I'm not made aware when prescriptions are canceled and replaced. So, caregivers wanting more information about medication so that they can help support the patient in adhering to medication is a big one. So these are all challenges, and I want to just kind of, before I go on to the next slide, I'd like to say, I think it's very easy for all of these ideas to feel really negative and really overwhelming. That's my honest reaction to the listening sessions. My first sort of reaction was that it's really hard to hear people talking about all of these challenges and not knowing exactly where to step in and how to help. And so I think that's why work like this, again, is so important. I think the work that PFCC Partners is doing to really have people come in and say, this is a safe space for you to share with us what you're experiencing. And then we can hopefully use our positions and our work to sort of advance some of these things. So for example, the end of life discussion piece. So people feeling like they're not, doctors are not comfortable initiating or having these conversations. They're not aware of how to have these conversations. We worked with a hospital in Idaho who was interested in just kind of improving around their end of life processes and having all of the providers in all of their clinics and hospitals understand this is how we need to address end of life conversations and advanced care plans. So we worked with that hospital to create a toolkit for providers that just walks providers through how to have these conversations, what documents are needed, when to have these conversations, just some of the different pieces of, advanced care plans that maybe not every provider is comfortable with. Maybe if you're a provider who doesn't do a lot of work with seniors, or you're maybe not a gerontologist, or you don't have a big patient population that's older or maybe chronically ill. So there's all different reasons why providers might not know this information. And so one project that came directly out of these listening sessions was working with this hospital to help support them in being better at doing these conversations. So all of this to say, we can let this stuff that feels negative sort of we could sit with it and let it kind of wash over us. And then when we're feeling ready, we can create programs and plans to actually try to address some of these things. So that's my own experience. I consider myself a highly emotional person. So I think it was an emotional project for me and for others. But again, it was just such a rewarding project because we were able to really pinpoint what the issues are and then maybe make suggestions for changing those things. Small baby steps at a time, but it still feels good to make progress towards that. And finally, this is my last real slide with content, just some reflections about the sessions. I know I already started reflecting here, but the sessions allowed the QIO, so Comagine Health, to learn directly from beneficiaries and families about their real lived experiences in the healthcare system. We work a lot with providers and almost really rarely am I interacting directly with beneficiaries, just the nature of our work. And so was a great opportunity for me and others to really learn directly from people who are living this experience every day, rather than come up with what we think might work and then see if it sticks. We hope that the work amplifies the voices of beneficiaries and their loved ones. So as I shared, we wrote this report and we really have tried to share it pretty widely so that just to get people thinking. I don't think any of the information would be shocking. I don't think every provider out there thinks they're perfect and their clinic is perfect and their hospital is perfect. I think providers know all too well sort of the challenges that our patients are facing. So it was nice to have an opportunity to write something and then share that out, just to get people thinking about, is there any little piece of information from this session that sticks out to you that you can work on in your organization, is really what we hope people get out of reading the report. We hope the series left participants feeling seen, heard, and empowered. I think that's so central to the PFCC Partners mission and is something that I don't always get to experience in my work because, again, I'm working really closely with providers. So just like hearing what people have to say, I think everybody wants to be heard. And in the healthcare system, we feel like, even myself, I feel like we're just such a small little blip in this broad system. And so having people listen and actually validate your experience and kind of care what you have to say, I think is so powerful. And then finally, the perspectives, as I shared, can really inform future projects for both Comagine and CMS. And so I'm excited to keep all of this information in mind as we start planning our next round of projects. And so which of these areas of focus can we start to hone in on? Because the reality is in healthcare, there seem to be so many issues and there seem to be so many things that need to be worked on. And so how do we really look at what patients are going through, look at what caregivers are going through, and create projects that can really directly address those things? So that's really all that I have. The next slide is really just an invitation to ask questions, make comments. This is my contact information. Please reach out with any questions. If you need help accessing the report, I can totally send that. You're welcome to take the slides and look at the slides and share the slides. Those are totally, fair game for you to use. I see a lot in the chat. So I'm wondering if, I don't know, Lindsay, if you want to go through the chat, if you want me to go through the chat, whatever.
Yeah. No, there's lots of great conversation and discussion in the chat, and just really appreciate everyone sharing their perspectives there. I'm looking to flag, some of the questions that we got in the first one. I'm gonna have to scroll up just a little bit. That came up was, how did you verify or ensure that we had a representative group of patients or of beneficiaries and family caregivers participating in the listening session?
Yeah, that's a great question. I think that I'm thinking of how to describe. I would say so as I shared, we first opened it up to any beneficiary in our 6-state region, and then had to open it to the national group. I think that in future versions of this project, if we had all the time and resources in the world, we would really like to have more of a targeted recruitment and maybe even have sessions. I could see this project organized where sessions for certain types of identities. So like maybe rural, a session for people living in rural areas, maybe a session for people of certain, ethnic, racial groups, maybe different languages. So in the ideal world, I would definitely like to do more to ensure that we are hearing diverse voices. I will say the group overall, we had both women and men participating, people of varying ages, people from all over the United States. We didn't collect any information about like people's job or education, but that's another way that you could organize these groups by like how well you know the healthcare system versus maybe people who know less. But that is a great question and is always a concern with this type of work, is how do we get as many voices as possible? And I think another piece is that if you're a PFA network partner, or you're involved in this work, maybe you have a certain like involvement in healthcare or a certain ability to contribute, whereas maybe our most vulnerable beneficiaries aren't in a position to be able to participate in this type of work. So that's another piece of it too, is we only used PFCC partners for this round, but maybe in the future there would be a way to really recruit anybody who wants to talk. So that's a great question. I always am thinking about that as well.
Yeah, thank you, Alex. I appreciate that response. We have one more question in the chat, and then we'll go to Maureen, Reverend Maureen. So Karen asked, is the work Comagine Health's QIO is conducting, are the other QIOs conducting similar projects? If you know.
That's a really good question. I know there's somebody in here, or there was earlier, somebody from another QIO. I think all the QIOs are working on the same measures, but I think the difference is what projects we implement. It's kind of an interesting program, the QIO program, because I would say we don't necessarily work together very often. And so I would love to see more of that, like more understanding of what other people are doing. I did go to the PFCC Partners Conference in 2023, and there was a QIO that was presenting about an immunization project that they did. So it was really fun for me to just see another QIO and kind of understand what they're working on. But we all work in different states. So Comagine Health has our 6-state region, and we are the only QIO in those states. Then the QIO for New York, there's only one in New York. So each state has their own. So that's a really good question, but I would say probably yes. This is, I think listening sessions is a big hot topic right now. And I know PFCC Partners works with other QIOs besides Comagine. So I'm sure there's a lot of similar work happening.
Thank you, Alex. All right. And is it Reverend Maureen?
Yeah, hi everybody.
Hi.
I didn't put the doctor down because that would get confusing because it's Doctor of Education. So
Okay.
I already put enough in the chat, so I don't really want to go over all that because everyone can read the chat. But as a clinical chaplain at Kaiser Morse during the peak of the pandemic, obviously I was able to read patients' charts, and I'm just summarizing briefly, what the healthcare providers and medical professionals, what they wrote in the chart. Most of the time I went in without knowing all that because I want to hear what the patient has to say. I don't want to have any preconceived. I want to know what's happening. And my background is teaching intercultural, interpersonal communication studies, customer service. So it's quite a background. But the main thing I wanted to say is one of the books that we had in our program is about social justice. And my question to Alex and Lindsay and others who may want to respond in the chat or whatever you want to do, just briefly, and then I'm going to turn it back to you because we're already at 5 to 1, is what I liked about this book, Injustice and the Care of the Souls. It's taking oppression seriously and ancestral. There's, trauma. There's a lot of things that are going on with our patients in the hospital. And being able, each chapter has a different demographic or population, anywhere from, up to seniors, addiction, powerlessness, ableism, looking at homelessness, pastoral care and gay men. And so what was really good for me to see is how you listen differently for how the demographics that we have. And it's real possible that the emergency or urgent care or whomever is working with our seniors may not be the best person to explain certain things because they're talking too fast, Alex, or it's their tone of voice, or here's my question. Let's just get to the question, and then I want to turn it back to you. Is what kind of training do we have for our healthcare professionals, medical professionals on the diverse demographics, and especially not just religion, but culture, race, age, gender. I put in all of that to understand that we're going to hear things differently when we're given prescriptions, when we're giving, discharge information. And some of our populations have come from trauma or distrust of the healthcare professionals. All right, I'm going to mute now. Go for it.
Absolutely. No, I appreciate that. And if you don't mind, I'd love if you could add the title of the book into the chat. I didn't catch the full
Please do,
title.
yeah.
I don't want to put Savannah on the spot, but Savannah, if you're still here with us, Savannah does a lot of our health equity work. So I'll just tee that up and say, with Medicare, CMS, and all healthcare in general, I think there's been a huge shift towards health equity and an understanding of exactly what you just described. Different people are going to come to the table with different needs, and some of those are cultural, and some of those might be age-related or regionally, like where you're located. So there's quite a bit of that work happening and being sort of encouraged within the QIO system as well. Savannah, if you're available, if you want to maybe speak for a moment just about some of the types of work that you see happening to get providers kind of trained up for working with diverse populations, if you want to speak to that a little bit.
Yeah, I will. I'll try to make it really short and sweet, because this is a topic I could talk about for every day. My work is heavily, and my background is public health. I have a background in health education and promotion, and then I have my MPH. And I've worked with Medicaid populations and Medicare. And I think the biggest thing and the main focus of the work that I do is not only building the competency of our internal staff, but also working with the providers and the partners, nursing homes, all of our partners in implicit bias, health literacy, cultural appropriateness, class standards training, ageism, and how that leaks into care, and really having some deep conversations about structural racism, systemic racism, because it takes more than one conversation. But I'm hopeful that as we continue to work in the health equity, and as we continue to ingrain health equity into the work that we do as an organization, we will have continued opportunities for capacity building so that our internal employees feel comfortable when working with providers. Because my role is my role. I can only be in so many places and host so many trainings. But I think this is why it's so important to discuss this. And also, it's bigger than us. It's policy, it's system change, as we know. It's listening to those who have experienced the healthcare system at a disadvantage, and really, really focusing from every corner that we can, and being the voice, I think, too, for people who have the voices to advocate for themselves, which, yeah, I'm very passionate. I could go on for days. So I know we're at time.
Yeah,
and
thank you.
I hope that gets to where, I hope that answers the question.
Thanks so much, Savannah. And I think this is a really big topic, Maureen. And I think starting in education is huge. So yeah, something that we can continue to discuss. But thank you for raising that question. Thank you, Savannah, for that additional information. And Maureen, thanks for putting the book in the chat and all of the additional information. I'm in Sacramento as well. So hey, neighbor. And finally, thank you to Alex for this really informative presentation. Obviously, you can tell by the chat this really resonated with a lot of folks. So we'll kind of go through the chat and pull some of the resources that everyone had shared and send that out in follow up, and make sure we send out the other information and the report from you and the team, Alex. And yeah, just want to thank you so much for sharing an hour on your Friday with us. So Alex, any last words for the good of the group?
No, just thank you so much, everybody, for participating or joining or listening. And I hope to be at future presentations hearing about other work that PFCC Partners is doing. So thank you for giving us a chance to highlight this project.
Yeah, amazing. And thank you for your leadership, throughout this process. So, all right. Well, thank you everyone. Have an amazing weekend. Happy Friday, and we look forward to seeing you on the next community of practice workshop. So thank you so much. Bye guys.
Bye.